did Malacha get Reuters?
Oh, she got a hold of Reuters, but she doesn't think FEMA is interested.
They don't think what?
FEMA
Yeah.
is interested.
But is Reuters calling you? She scheduled him for a day without talking to me.
You do?
I want to talk about how people can access FEMA if the county's not determined to be a natural disaster site, because people don't realize that they can access FEMA assistance privately,
Exactly.
and they
That's
need
a
to know
great
that.
point.
Okay. I hope so.
Really?
Well, let me tell you something. If it's Hillary Clinton, I'd rather have the devil.
Yeah.
So bring me Satan, because at least I know where I stand.
You're on YouTube.
That's fine.
That's
I
what we all
honestly
are.
believe that.
Yeah.
So I have no issue saying it on YouTube. Give me Satan over Hillary Clinton. Yes. Right. And how's that gotten us in the past? I mean, we've got a bunch of politically correct people. Well, you don't always have to be a Democrat. You can vote for the person that's better.
I'm an independent.
That's fair enough.
I look at the people, not the party.
No, you're good. I love you too. You know, I think that's a little bit of Leonard Skinner there. Is that not correct, Schragius? A little Leonard Skinner there. Can't pass that up. I'll tell you what. That's a little before my time, but his music lives through. I love Leonard Skinner.
Really? Was it really
Before your time.
Before my time. Sorry. Well, I was born in '72.
We're going to have to card the host.
You know what, truly though. Good morning, folks. Welcome to JP and Dr. B. Dr. B is off on Monday, and he will not be here today, but we have got Dr. Norm Clothier in studio, our resident expert doctor, and we sure appreciate having him here because we are on Controversy Monday today. We have been posting all week to tune in because today we are going to tackle that big question about women's health screenings. And you know, I mean, evidently, Dr. Clothier, you have said there are plenty of opinions out there right now.
Absolutely. If you know a person, you have an opinion about mammography if you've ever discussed it. It is amazing, the controversy.
Well, and especially a female person.
Absolutely.
Yeah, because I know that my wife is not a big fan of the mammogram.
Exactly. And that's part of the challenge to dealing with mammography is as much as we talk about screening tests for things, a lot of people don't want to do them. You know, we talked a few weeks ago about colonoscopy, how important that is with family history and with screening of everyone. If you're alive at 50, you're due for screening. I would say easily 80% of people that I then refer for screening at age 50 have a whole list of arguments as to why they don't need to screen. And, you know, the only indication is if you're alive at 50. So it's, mammography is much the same. A lot of women do not like the idea of mammography and want something more comfortable, maybe more precise than that. But as we talked about also in November in Men's Health Month about prostate cancer screening being highly controversial as to whether it's really, the yield is really worth the screening effort. That's really kind of where we're starting to get with mammography too, and that's extremely controversial.
Now, with lack of a medical background, I'm going to just argue just this one point to create some controversy. Of course, the prostate, you don't die from it, you've said. That's not generally something you die from.
Bulk of the evidence.
But with breast cancer, if you don't detect it and go after it and get it, you will die from breast cancer. Is that not right?
Yes, I'd say that's true for most types. Absolutely. So part of the controversy at this point is how much harm is done by screening versus how much benefit is had by screening. So let me talk a little bit about that just for people who maybe aren't as used to the idea. You know, we talk about some things that I think sometimes people just don't realize what they are. A mammogram is an x-ray of the breast, essentially, which is designed to pick up changes that could be suggestive of cancer. And if you think about just the process of screening, there are really three elements that come in. One is you want to screen a group where it's likely to find a diagnosis that'll make a difference. In other words, if you screen 25-year-old women for breast cancer, you won't make a difference because breast cancer is nearly non-existent at that age. So we start to talk about the age. Then you start to talk about cost. No one that I know likes to consider cost with medicine, but the bottom line is insurance won't cover things that is not cost, that it's something that tends to not be cost effective, whether we like it or not. Many of your health decisions are more based on what insurance will cover than on what your doctor and you want to have covered.
Well, and that's what I was going to get. I mean, it's no longer. It's very interesting. Like if the insurance company doesn't think you need it, or if they think you're too old,
exactly,
they're not going to pay for it.
It's over.
And it's cost prohibitive. I mean, how do we allow something like that to go on? I mean, I just don't get that.
I think we have signed over many of our rights, honestly, and the bottom line is you can still pay for something on your own, but I know very few people that really jump in there and want to do that.
I mean, it seems like a basic procedure, Dr. Clothier, could be $1,500 to $3,000 just like that.
Oh, easily. So that's part of the cost of medicine is a whole different topic, but the cost of screening is part of what plays into it. And then the third factor is that you want to see an intervention with screening that makes a difference. Much like, as you referred to on prostate cancer, we see that over time it's been shown that more men die with a prostate cancer than from a prostate cancer. And it is true that women, the tendency of a breast cancer is eventual death. But if you cannot screen that early enough to make a difference in that process, then it's not a valid screening test. And so those are the factors that we have to consider. So basically, if you think about from the standpoint of, say, a television or a phone, or even a computer, if you think about the resolution difference over time, think about where your phone was 10 years ago, or your TV 10 or 15 years ago. So now we have better resolution with mammography as well, and we have digital mammography that tends to overread or read over what the radiologist even reads and point out areas. So part of the challenge is we're seeing things that we never saw before. And so that leads to the potential for an overdiagnosis or over concern, if that's a fair phrase, such that if there's a tiny calcification, it maybe never would have been visible 10 years ago, but now it's visible by mammography. And then that can lead to a procedure, like a biopsy, that can lead to infection or pain or scarring or a host of things that probably is an unnecessary step.
Well, and I mean, we're not even just talking a regular infection. That can become a staph infection, correct?
Absolutely. So it could be life-threatening, definitely.
Yeah, because staph infections are pretty serious.
Right. Very much so. I mean, people end up in the hospital. Sometimes they die from it. And, that's a very serious issue. So there basically are some new guidelines on mammography. When I was in medical school way back, 20 plus years, 25 plus years ago now, it's hard to believe, we used to talk about doing a mammogram as a baseline at age 35, and then once every other year from 40 to 50, and once a year from 50 onward. And that was based basically on the idea that if you had your baseline mammogram when you were young, you could then compare changes over time. Well, as I was just referencing, if you start at 35 and then by 55, the resolution is unbelievably more visible in terms of the tissue. That alone can lead to a couple of problems. One is there may be something that was normal all along, you just couldn't see it early on. And the other is that by then you've had 10, 15, possibly 20 mammograms, all of which involve radiation. And radiation is one of the known causes of cancer. So there's always that fine line between enough radiation to diagnose and not so much radiation that you basically can induce a cancer. And that's part of the challenge. So the newest recommendation that came out from the American Cancer Society is to screen once a year from 45 to 54, and then consider every other year from then on, one of those factors being how long you think someone would live. And I got to tell you, there's nothing harder than a discussion with a patient to say, I don't think we need screening because I don't think you're going to live anyway.
Yeah, that's a great conversation.
'Cause
Fantastic.
None of us, no one in medicine, I can tell you, wants to view that situation. Even if somebody has a desperately terrible disease, you never want to think, oh, you know, in a couple of years you're not going to be here, so, you know, we don't need to do that. That's just not going to happen.
Well, folks, I'll tell you what, this segment's been brought to you by Family Healthcare Associates. This segment is, again, it's supported by the idea that we want to provide good health for all families by having good information. And Dr. Norm Clothier and the Family Healthcare Associates provide you with all of your family needs from prenatal to seniors. Family Healthcare Associates at FHCATX.com. That's FHCATX.com. And we are talking women's health, and we're talking specifically women's screenings. We're talking, and again, Dr. Clothier, we have mammography. Did I say that correctly?
Yes.
And we're talking mammograms, basically, and we're going to also get into further physical, I say physical because do men call them physicals and women don't, or are they women physical as well? Okay,
right.
Health screenings or physicals. As we go into the next segment and talking about the controversy, Dr. Clothier just dropped a big bomb on us in regards to what the American Cancer Association is suggesting, and I'm going to ask him here, and when we come back, who on earth gets to decide what they release and who says, hey, that's a good idea? My guess is it could be some dude that's standing behind that. Only I say that because it's more fun to say that. But we'll find out when we come back, that's for sure. So you are with JP and Dr. B on 620 AM KEXB. In the third segment, we are going to bring on some more of the victims of the tornado that were victimized by Landmark West, and some more unfolds on that story. Stay tuned.
Yeah, we'll hit on the alternatives to mammograms, a couple of the other recommendations, and then I'll have Smears briefly outline again all the details of that, just because I think that's difficult radio play.
I do too.
Yeah.
Well, what I'm thinking is just the controversial side of do you or don't you?
Right, absolutely.
You know.
And the bottom line to that we'll wrap up with. So I think that's a fair thing too. So.
I do want to ask you, when we come back, I want to ask you about, who on earth gets to determine what the American Cancer Association releases? Who are these people? I mean, are these people that are even old enough to have mammograms, or,
That's very fair.
I think, because I have those questions,
Sure.
Or are there just some guys that
Oh yeah, and I
don't
think
give a crap about.
Yeah, that's sometimes the view and I take that's even the view from doctors at times, is these are people who don't do clinical medicine, and they don't see patients day to day who have concerns.
Yeah,
it's very easy to sit back and say, just tell them if their life expectancy isn't more than 10 years, you don't need to screen. But they're never having that conversation with a person.
Yeah.
And that's a big.
What was one of the,
issue.
and I mean more of the more recent movies, and I'm talking in the last 30, 40 years.
There only been movies for about 100. But go ahead. Yeah.
Well, but I mean, I don't want to talk about Humphrey Bogart.
Yeah.
That was
okay.
before his time. So.
Was this a talkie? Okay, go ahead.
Fireside.
No, what I wanted to get to was, there was a movie that came out in, I want to say either the 90s or the late 80s, where a doctor was pompous ass, wealthy, good family, and had cancer patients and was pretty hardcore.
Yes.
And then he got cancer and was treated as crappy as he was treating people.
Absolutely.
Was it John Hurt?
Yes, I believe it was. And what was that? That was. I know the one you're talking about. I just can't quite place it right now. I believe it was.
It was throat cancer, wasn't it, or something like that?
Yeah, and that I'm confusing it. I think with.
And he was a surgeon.
Yeah, there was a guy shot in the head in one movie that was the guy who played the president in Air One and such.
Harrison Ford.
Harrison Ford.
Yeah,
that's not the one. It's the other one,
No,
right?
it's the other
I think
one.
it was John Hurt. I can't recall. Let's look that up.
Okay.
Yeah.
But he had got
Mammograms
cancer, and all of a
and
sudden
John Hurt.
everything changed.
Yes. And it is very different being on the other side. I tell you, just from the standpoint of signing consent forms, we hand people consent forms all the time about you may need blood transfusion, you may die, whatever. It's very different when you're signing, especially like for your child. Yeah. If they're having their appendix
That was
out.
who? Okay, what was the name of the movie? No.